Hi, welcome back to part 2 of our urine analysis and dipstick interpretation series. Now it's your turn to test yourself on the knowledge of the previous video. Here's a brief summary of the last video. You can have a quick look, but let's dive into the quiz now. Here's the first one. A patient presents with alburia, which is pain during urination, and optically the urine presents cloudy. The dipstick shows positivity for leukocytes, and additionally, also nitrate, heme and protein may be positive. What's your diagnosis? This is the classic finding of a urinary tract infection, so a UTI. Leukocytes point towards inflammation. Nitrate can be present due to some bacteria producing nitrate, but not all of them do this. In UTI, there can also be small amounts of heme and protein in the urine when there is microbleeding due to the infection. In UTI, bacteria like E. coli can be found in the urine, but they are not measured with the dipstick. Alright, here's the next one. Again, in this example, leukocytes are positive, but this time there is no bacteria found in the urine. So what's your guess? Again, leukocytes tell us there's inflammation happening, but this time not enough to make the urine cloudy. And since there is no bacteria present, we know it must be an acute interstitial nephritis. Again, here small amounts of heme and protein are often present, but not necessary for diagnosis. Remember, leukocytes are the marker for inflammation of the urinary tract or kidney. Here's another example. This is a patient with little protein in the urine, and clinically he seems fine, but his creatinine is elevated and he has a lower GFR, let's say of 38 milliliters per minute. What's your guess? Do you remember what proteins are measured in the dipstick? Right, it's only albumin. Only albumin. And albumin can enter the urine in two ways. First, in glomerular damage, and second, when there's bleeding in the urinary tract, for instance due to a stone. But in combination with the chronically elevated creatinine, we know that this fits to chronic kidney disease, so glomerular damage. You can check out our video on proteinuria over here. Next example. Again, there is some positivity for protein, but this time it's a young and healthy individual. Let's say this is an incidental finding in a 20-year-old athletic young man. This could be indicative of postural or benign proteinuria. It happens after physical exhaustion or long hours of standing during the day, but the key point is it's benign and it resolves again. Still, other diagnoses like kidney damage need to be ruled out since they are possible. Okay, let's move to another case. This time there is lots of protein present in the urine, and also optically we see foamy urine. The patient has massive bilateral leg edema and his serum albumin concentration is below normal. What's your diagnosis? How do we call massive amounts of protein in the urine? Right, that's nephrotic proteinuria or nephrotic syndrome. You can check out this video to learn more about this syndrome. Nephrotic syndrome is characterized by more than 3 or 3.5 grams of protein, especially albumin in daily urine. And this leads to albumin deficiency in the blood, which creates massive edema. And usually there is no or only little blood, since this is a selective damage to the glomerular filter alone. Let's do another one. This time there is strong positivity for blood, but only some protein. Clinically, the patient shows signs of acute kidney injury. For instance, sudden onset arterial hypertension and a sudden increase of serum creatinine. This time sudden, so acutely, and not chronically elevated like in CKD. How do we call this syndrome? This is called nephritic syndrome. And in contrast to nephrotic syndrome, this is more of an inflammation in the glomerulus, leading to not only protein, but also blood into the urine. It's a type of acute kidney injury. And you can check out this video to learn more about acute kidney injury. Remember, nephrotic was about losing protein, so O in protein and nephrotic, and nephritic sounds more like itis, so inflammation, and it's more about blood than protein. And the protein count in urine is typically below 3.5 grams per day. Here's another one. Here's a patient from a car accident. His leg was crushed and now his urine dipstick shows hematuria, and optically it's not red, but brown. What's your diagnosis? Do you remember what could cause positivity for heme? This diagnosis is rhabdomyolysis, so the breakdown of muscle tissue. In rhabdomyolysis, there is breakdown of muscle tissue, so myoglobin is released in high amounts into the blood, and it's then filtered through the kidney and enters the urine, since it's a very small protein. It consists of heme, just like hemoglobin, and therefore also produces positivity for blood in the urine, without the actual finding of actual erythrocytes being present. And the brown coloring comes from myoglobin itself. It's due to the iron atom inside of it. Okay, here's another typical pattern you should know. Again, there's hematuria in the dipstick. Usually doctors would administer a microscopy of the urine in any case of hematuria to see if red blood cells are present in high amounts and to see where they come from. But we are going to ignore this for this video and we'll cover this in another one. In this case, the decrease in haptoglobin is leading us into another direction. So what's your diagnosis? The right diagnosis is hemolysis. Haptoglobin is a molecule in the blood which intercepts free hemoglobin, since it's very oxidative. And this is the case when red blood cells get destroyed in the vessels, which is hemolysis. And then haptoglobin itself is brought to the bin, since the oxidative molecule hemoglobin needs to be removed. A reduced haptoglobin is therefore a sign of hemolysis. Here's another case. A patient has a new diagnosis of pulmonary tuberculosis, but suddenly during treatment his urine turns red, but the dipstick is bland. Do you remember what can turn the urine red with no other signs in the dipstick? Right, it's foods or drugs, and in this case it's rifampicin, which is an antibiotic used in tuberculosis treatment. Okay, here are the last 3 examples for today. This is the result of an 83-year-old lady with dementia. She has recurrent episodes of hematuria in the urine. I know this example is pretty hard to guess. This hematuria is due to a urinary catheter. I know it's impossible to know from the information I gave you, but I really want you to know about this. Due to the dementia, she carries a urinary catheter. And a urinary catheter can create tiny lesions in the urethra or the bladder, and this causes microbleeding into the urine. Remember that there can also be 2 diagnoses at the same time. A patient in hospital may have a urinary catheter in order to collect his urine, and therefore lots of blood can be present in the urine. But still, he might have also nephrotic syndrome, so there might be massive proteinuria and massive hematuria. It's good to first think about one-fits-all diagnoses, but often there are multiple common reasons coexisting. Here's the second last example for today. Here's a patient coming into the ER with acute abdominal pain. His urine is brown and the dipstick is positive for bilirubin and glucose. Remember what I said. Think of multiple diagnoses. Glucose typically occurs in diabetes mellitus. So this might be the first presentation of a so far untreated diabetes mellitus. But what about the acute pain and elevated urine bilirubin? This is a classic finding in cholestasis. The brown color comes from bilirubin. And here's your last case for today. This is the dipstick from a comatose patient. This is the result from his urinary catheter. The dipstick is positive for glucose and ketones. So what's your final diagnosis for today? The right answer is diabetic ketoacidosis. Ketones could be present in longer periods of fasting, and people wouldn't be comatose. But people without diabetes would also have no glucose in the urine. So the combination of glucose and ketones is indicative of diabetic ketoacidotic coma and needs immediate treatment. Alright, that's it for today. Tell me how you did in the comments and feel free to ask any questions. And remember that these are just imaginary and exemplary cases. Don't forget to think about multiple diagnoses at the same time. It's more common than a rare disease which fits all criteria. Feel free to subscribe and I see you in the next video.